The threshold for a surgeon to be able to say the leg cannot be saved and this is best treated with an amputation is a moving target. And you know, that statement is something that has been said for a long time and is something that we still say. There are some legs that we cannot save and are going to be best treated with an amputation. But the threshold for making that statement really depends on our ability to perform successful limb salvage. Go ahead and give it a run. Like, you know, just like walk, don't hold back.
Don't hold back?
Don't hold back. It's pretty strong.
I was on my motorcycle with a bunch of friends and I lost control of the motorcycle and got into a really bad accident. Broke almost everything.
There you go. It's great. You just need to develop a little bit of confidence with it.
Yeah,
you know,
definitely. After 3.5 years.
3.5 years being in a wheelchair, it takes a little time to.
I didn't even think I was going to be able to walk this good.
You're going to walk better than you are walking now. It's going to keep getting stronger and stronger. So the typical patient that we will see is somebody who has an infection combined with missing bone in the leg or the thigh bone. But let's just use the leg as the typical example because that's the most common situation. So somebody has a terrible accident.
After the accident, I was in the hospital for 4.5 months, which was really tough. I had a total of 12 surgeries within a month, which was horrible. I was in ICU for a month. After the hospital, I still didn't even feel like myself, probably until a year later. And then that's actually when I started coming here. He
was treated by a colleague of mine in upstate New York, and you know, the guy did all the right things, but unfortunately he developed an infection, which is not uncommon in these kinds of cases. He had a very severe injury with soft tissue injury.
When I initially got into the accident, they thought about the amputation already. The only reason why they didn't is because I was able to move my toes. So they kept it, but then I kept getting infections because I had a bone infection. And one of them got treated with the prior doctor. Then that's when I came here, and not that I knew it wasn't going to get amputated, because once I started seeing what goes on here, I knew it was in the right place.
By the time he came to see me, he had an infected non-union with 6 inches of missing bone and an additional inch of shortening of the entire leg. And so what we needed to do was cut out a 6-inch segment of bone. We needed to lengthen the leg. We needed to reconstruct the bone defect and treat the infection. And we did that with a technique called trifocal bone transport, with an external fixator that has basically 3 levels: a first floor, a second floor, and a third floor. And there's 3 things going on. You know, the elevator from the third floor is coming down. The elevator from the first floor is going up until they meet in the middle, and that's how we reconstruct the bone defect. And then the space, the distraction, is all the new bone that grows and it heals, and I'll show you all these things on the x-rays. This is a nice picture that really shows the infected, dead segment of bone. You can really see how it demarcates. You can see it almost doesn't look quite like normal bone, and that's what happens when there's infection and when there's a dead piece of bone that is in place. This is a picture of the bone defect. So this is 6 inches of missing bone. This is the top of the tibia, this is the bottom of the tibia, this is the defect. And these little pellets are antibiotic pellets that we put in at the time of surgery. What we're doing here is, this is the knee joint, this is the bone defect that I showed you. And we cut the bone here, right? So we'll call that the third floor. The second floor is the space, is the bone defect. And the first floor is down by the ankle where we cut the bone. And so what we're doing is we're lengthening the bone in this direction on the bottom part to move this piece of bone up to fill in this defect. We cut the bone over here on the top part of the tibia below the knee to move this piece of bone down to fill in this bone defect. Okay, that's the idea of bone transport. So as we're progressing, this is several weeks later, you can see that this piece of bone is moving down and getting closer. You see how the defect is actually decreasing in size. So this piece of bone is moving down. This is new bone. This piece of bone is moving up. This is all new bone, and this is the bone defect that is still there but smaller. Bone defect was here but no longer is. Now these two pieces of bone are in contact with each other. This is all new bone, lengthened bone. This is all new bone, lengthened bone, and it looks like there's very little bone in there at this point because it's still immature. You can see a few weeks later, you see how it's progressing. The calcification of the new bone is improving. The docking site is progressing. Further along, you can see the regenerate further improving and calcifying. Further improving and calcifying. The docking site where the bone defect was is healing, and this is what it looks like when it's all healed, and then we take the fixator off. So again, now you've got knee, ankle. This is all the new bone that is filled in beautifully. This is where it docked and is healed. This was the big defect site, and this is all new bone that has healed. And so that's a leg that he can walk on now. These are some pictures from surgery. This is the knee, this is the ankle, and this is the necrotic piece of bone that we had to excise. So this is the 6-inch segment of bone that needed to come out. This is what the fixator looks like soon after we start the process. So this is the lengthening is happening at this level, and this represents the defect site. Now you'll notice over time this is going to decrease in size, and this are going to increase in size. This is much further along in the transport process, and as I promised to show you, this space has increased, this space has increased, and the defect site has decreased. So that corresponds to the progression, and you can see the process moving along. Okay, so let's have a look. The leg looks beautiful. Look at that. The leg looks beautiful.
I mean, I didn't even know places like this existed. It feels amazing. It feels like my leg again, which it didn't for a very long time. My leg is the same length as the other one now, and once again, I didn't even know that was possible. I didn't know you could grow bone or lengthen bones or anything like that. And now I feel like me.
Here, let's bend your knee. All right. Let's plantigrade on the floor. Maybe turn this way. Good. Turn your back to me. Yeah. Nice alignment. Leg lengths are equal. You can feel the pelvis height. So that looks great.
First time I'm standing and you're sitting.
I know.
Everything is fixed except my left arm. I have a plexial injury, and that's going to be worked on in the next couple of months, and then I should be close to 100%, which I'll take. I didn't even think I was going to be able to walk again, to tell you the truth.
This the start point, this is the end point. That's all new lengthened bone. This is the docking site. This is where the non-union was and the big bone defect. This is where that 6-inch defect was that we filled in. And then all of this is new regenerate bone on the bottom. It really looks great. Every time I look at it, the quality of the bone looks better and stronger. So the chance of this breaking or refracturing at this point is extremely low.
Okay.
You'd have to have a pretty bad fall.
Okay.
So I think just walking and using it in the way that feels comfortable for you and feels natural is quite all right at this point.
Okay.
So I think you're good to continue walking. You can do your thing.
Yeah?
I'm comfortable with you starting to really walk.
Can I wear sneakers outside of the house yet?
Yeah.
Yeah?
Yeah. It's really amazing, to be able to have this kind of an impact on a patient's life. It's not about necessarily, just increasing the length of the leg or correcting the deformity, which is incredibly important. But here, we're really providing a service that is an alternative to amputation. Part of it is going to be confidence.
Definitely.
Feeling comfortable
Yeah.
with the idea of doing
Mentally way more than physical, I
Right.
noticed.
I think that's there's gonna be some of that. This technology has enabled us to save people's legs. And the functionality after this is tremendous. I mean, once the bone is healed, the bone is healed. And you would never even have remembered a year or two out that this person had this huge bone defect and was a candidate for an amputation. Any questions for me?
No, I mean therapy, get to walking. I couldn't be more excited, man.
Me too.
This is amazing.